Greetings from Indian Journal of Anaesthesia. I am Dr. Kiran Mahendru from the IJA team, and I'll be presenting an original article published in the April 2025 issue of IJA. The article is on effect of preoperative oxytocin infusion on haemodynamics among women undergoing elective caesarean section under spinal anesthesia, a randomized controlled study. Spinal anesthesia-induced hypotension during the caesarean section is reported in up to 30 to 83% of the cases. Several interventions are used to avoid these episodes, including displacement of the uterus and preloading or co-loading with crystalloids or colloids. Recent meta-analyses have reported that vasopressors like mefentermine, phenylephrine, and norepinephrine, except ephedrine, are better for managing hypotension with low rates of reactive hypertension or rhythm changes. The timing of oxytocin administration during the pre-labor caesarean section for preventing PPH varies in various studies. The oxytocin infusion has been started even before the fetal delivery to initiate the uterine contraction. Uterine contractions in early labor increase the heart rate, and autotransfusion of 300 to 500 ml of the blood from the uterus to the systemic circulation following each contraction. The primary objective of the study was to compare the hemodynamic effects of preoperative administration of prophylactic oxytocin to its initiation after fetal delivery among women undergoing elective pre-labor caesarean section under spinal anesthesia. The secondary objectives were to compare the both groups' vasopressor and oxytocin requirements. The hypothesis of the study was that preoperative administration of prophylactic oxytocin can reduce the fall in systolic blood pressure compared to its initiation after fetal delivery during caesarean section. Ethical approval was attained for the study and was registered with CTRI. It is a randomized controlled trial with a study duration from June 2017 to December 2018. The patients included were women aged more than 18 years with singleton pregnancies, with more than equal to 37 weeks of gestation, undergoing elective pre-labor caesarean section under spinal anesthesia, and belonging to ASA physical status 2. Patients with hypertensive disorders of pregnancy, pre-labor rupture of membranes, risk factors for uterine atony like previous PPH, macrosomia, multiple gestations, chorioamnionitis, polyhydramnios, and uterine fibroids, any previous uterine surgery except for one previous caesarean section, placenta previa and morbidly adherent placenta, presence of anemia with HB less than 10, coagulation abnormalities, and thrombocytopenia with platelet counts less than 100, preoperative systolic blood pressure of less than 90, and any contraindications to spinal anesthesia or uterotonic agents were excluded from the study. Simple randomization was done using computer-generated random numbers, and participants were randomized into two groups. Sequentially numbered sealed opaque envelopes were used for allocation concealment. A staff nurse present in the preoperative area opened the envelope and informed the anesthesia assistant to prepare the interventions. The participants, investigators, outcome assessors, and statisticians were blinded to the treatment allocation. The two groups were Group C, which included 35 patients who received only the preloading infusion, and Group O, which included 35 patients, received preoperative oxytocin at a rate of 6 milli-international units per minute using a dial flow meter. The oxytocin infusion was prepared by adding 3 units of oxytocin to a 500 ml normal saline bottle and given at a rate of 60 ml per hour through a dial flow meter. After the baby's delivery, an IV infusion of 5 international units of oxytocin was administered over 5 minutes in both the groups. Now, patients were pre-medicated with oral famotidine and oral metoclopramide orally before the surgery. All of them fasted overnight. Clear liquids were permitted till 2 hours before shifting to the OR. After shifting to the OR, Peripheral IV catheters were secured in both the forearms. Baseline parameters such as NIBP, with a cuff placed in the left arm, pulse oximetry, and ECG were recorded in supine with a lateral tilt, with a wedge placed under the right buttock, as well as in the left lateral position. Heart rate, systolic BP, MAP, and non invasive cardiac output indices like cardiac output and stroke volume were recorded. As per the hospital protocol, both the groups received IV preloading with a pre warmed 500 ml normal saline before spinal anesthesia over 20 minutes, and the maintenance infusion was then continued at 100 ml per hour. The fluid was administered through the IV cannula placed in the left arm, which also had the NIBP cuff. In the group O, that is the oxytocin group, oxytocin infusion was started through IV access in the right arm. To ensure the blinding of the assessor of the hemodynamic parameters, the authors gave a preloading infusion in group O in the left hand, and in group C, the patients received normal saline infusion through a dial flow meter in the right hand. Left lateral position was given, and the attending anesthetist in the OR performed spinal anesthesia in L3 L4 intervertebral space, and 1.8 ml of 0.5% hyperbaric bupivacaine was given through a 25 gauge spinal needle. Participants were then turned from a full lateral to a supine position with a lateral tilt. Fetal well-being was assured by the obstetric team, which assessed the fetal heart rate before positioning for spinal anesthesia and before the start of draping. After the completion of sterile draping, the levels were checked every 5 minutes till half an hour until the drapes from T6 level upwards. Once the sensory level of T6 was ensured, the surgeon started the caesarean section. All the hemodynamic parameters were recorded every minute until the delivery of the baby, and then every 5 minutes subsequently till the end of the surgery. Hypotension, described as a systolic blood pressure less than 90 following spinal anesthesia, was treated with a bolus of IV phenylephrine 20 microgram and 100 ml of normal saline, which was repeated if necessary. Additional IV oxytocin, 3 international units over 3 minutes, were given based on the obstetrician's clinical assessment of the uterine tone. Oxytocin, 10 international units in 500 ml of normal saline, was administered at a rate of 100 ml per hour following the skin closure for 4 hours after surgery as per the hospital protocol. Uterine massage and exteriorization were not done routinely during caesarean section, and if it was required, the patients were excluded from the study. The primary outcome of the study was the change in systolic BP after spinal anesthesia in both the groups, and the secondary outcomes were other hemodynamic parameters like heart rate, mean arterial pressures, cardiac output, and stroke volume, total amount and additional doses of IV oxytocin and phenylephrine during the surgery, skin incision to delivery, and uterine incision to delivery time intervals. A pediatrician who was blinded to allocation recorded the APGAR scores of the baby, and the fetal cord pH assessment was performed only if the APGAR score was less than 7 at 5 minutes, suggesting a probable birth asphyxia. The sample size was calculated using the methods for comparison of means. We are using a fall in systolic BP in the control group to be 28.8 millimeter mercury from a previous study, with an anticipated fall of 18.8 in the oxytocin group with a standard deviation of 12. The minimum sample size required was 32 in each group. The authors enrolled 70 patients in the study to account for technical difficulties or those requiring conversion to general anesthesia after the enrollment. SPSS 19 version was used for the statistical analysis. Coming to the results, of the 70 patients who were recruited from the study, 3 were excluded from the before the allocation. The final analysis was done for 67 patients, and 3 patients required conversion to GA for failure to achieve the effect for performing caesarean section. The baseline characteristics of the study population, the age, height, weight, BMI, gestational age, and the sensory level achieved were comparable in both the groups. The time intervals between skin incision to baby delivery and uterine incision to the baby delivery were comparable in both the groups. Now, as you can see in this figure, this is comparing the primary outcome, that is the systolic blood pressure. Here you can see that the black lines denote those who did not develop hypotension and the red lines denote those who had hypotension. So from this, the incidence of hypotension was higher in the control group, that was 59.4%, than in the oxytocin group O, which was 8.6%. And the results were statistically significant. Coming to the cardiac output, the mean cardiac output increased by 1.08, 1.08 and zero 0.4 liters per minute from the baseline value immediately before administration of the spinal anesthesia. It reached to a nadir at 1 minute for the group C and at 2 minutes for the group O. Now, following the spinal anesthesia, the mean cardiac output remained significantly higher in the group O than in the group C till 10 minutes after the baby delivery. So, this is the time point for baby delivery. And here you can see at 10 minutes, up till 10 minutes after the baby delivery, the mean cardiac output remained significantly higher in the group O, which is denoted by the black lines, than in the group C, which is denoted by the dotted lines. Now, after this 10 minutes, the cardiac output was maintained until the end of the surgery in both the groups. Coming to the systolic blood pressure, mean systolic blood pressure increased from a baseline value of 113 to 116 in group O and 115 in the group C before spinal anesthesia. Now, after giving the spinal anesthesia, the lowest systolic blood pressure was observed at 1 minute in both the groups, as can be seen in this second figure. However, the fallen systolic BP at this point was higher in group C than in the group O, and these results were statistically significantly different. The mean systolic blood pressure was significantly lower until 15 minutes after the baby delivery in group C than in group O. That is, in the control group, the systolic blood pressures were significantly lower until 15 minutes after the delivery of the baby. After 15 minutes, the systolic blood pressure was maintained without any significant difference in both the groups till the end of the surgery. Now, coming to the other parameters, the time interval from placement of IV cannula to the placenta delivery was significantly lower in the oxytocin group than the control group. The number of doses, total dosage, and additional dose requirement of phenylephrine and oxytocin were significantly higher in the control group than in the oxytocin group. None of the patients reported any side effects such as rash, flushing, nausea, vomiting in the perioperative period. The Apgar scores at 1 minute and 5 minutes were comparable in both the groups, and none had a score of less than 7 at 5 minutes. Now, women undergoing pre-labor cesarean section at term under spinal anesthesia who had initiation of oxytocin after the fetal delivery have a significantly higher incidence of hypotension than those who had it initiated before the delivery at the time of skin incision. Pre-op administration of oxytocin augmented the cardiac output and the systolic blood pressure, which helped maintain the hemodynamic status after giving spinal anesthesia. Women also had a lower requirement of cumulative oxytocin and phenylephrine dosages. Various regimes are reported regarding the timing of initiation, dosing, and speed of administration of oxytocin during the cesarean section. Dosage ranging from 0.5 to 10 units were reported to maintain the uterine tone and reduce the blood loss even in non-elective cesarean sections. Labor induction with oxytocin started at doses varying from 3 to 6 milli-international units per minute, which provides oxytocin levels which are similar to those at spontaneous labor and is considered to be safe for the baby and the mother. The beneficial effects of prophylactic oxytocin administration before delivery during cesarean has been demonstrated in a previous study. which was an observational study where oxytocin was started preoperatively, resulting in a lower blood pressure fall and a lower rise in heart rate compared to oxytocin initiation after fetal delivery. Starting prophylactic oxytocin preoperatively could initiate the uterine contractions, contributing to autotransfusion from the uterus to the maternal circulation, thus increasing the cardiac output and the systolic blood pressures. It helps to maintain the patient hemodynamic stability with less intense fall in the blood pressure and reduced requirements of vasopressors. The effects of synthetic oxytocin varies with the uterine oxytocin receptor expression as well as some clinical factors like BMI, parity and the gestational age of the patient. Future studies are needed to assess the intensity and frequency of contraction using instruments like durometer and tokometers to confirm the effect of pre-op oxytocin initiation on the hemodynamic parameters. Towards the end of the surgery in the study, a drop of BP was noted in the group O, that is oxytocin group, with 3 patients showing a BP fall of more than 20% requiring vasopressor administration. This could be either due to reduction in the autotransfusion of the blood over time or because of oxytocin's vasodilatory effect. When oxytocin was used after baby delivery, higher doses of oxytocin were used to maintain uterine tone, which could lead to vasodilatory effect on the small and peripheral arteries, leading to fall in blood pressure, which was observed in the control group. Higher doses was associated with of oxytocin can be associated with complications like hypotension, arrhythmias, hypernatremia, neonatal seizures, hyperbilirubinemia, and retinal hemorrhage. Early delivery of placenta seen in group O might have resulted in lower doses of oxytocin and their impact on the hemodynamic changes. However, hypotensive episodes were lower after baby delivery, probably from autotransfusion and relief of aortocaval compression following the delivery. Similar APGAR scores in both the groups suggest the absence of any adverse effects of prophylactic oxytocin or phenylephrine on baby as reported in earlier studies. The limitations of the study are limiting the study to women who had elective pre-labor caesarean section will limit the generalizability of the study results, as those undergoing intrapartum caesarean section may have additional hemodynamic changes from uterine contraction and the fluids administered. The sample size was limited to assess the incidence of side effects of oxytocin or for the occurrence of PPH. The reports are inconclusive about the effects of preloading with crystalloids on BP after spinal anesthesia, as was used in this study. To conclude, preoperative prophylactic oxytocin infusion provides better hemodynamic stability in pregnant women undergoing caesarean section under spinal anesthesia in terms of systolic blood pressure and cardiac output, significantly decreasing the vasopressors requirement. In addition, oxytocin requirement to maintain the uterine tone is also reduced in these patients. Thank you.